Welcome. I'm Dr. Jennifer Anders, the Associate State Medical Director for Pediatrics here at MIEMSS. If you've already seen the 2020 Maryland protocol rollout, you may be aware of the upcoming change adding pediatric inclusion to the termination of resuscitation protocol. This protocol provides detailed criteria under which pediatric TOR can take place. This protocol also relies heavily on the judgment of EMS clinicians. So for that reason, we have produced this learning module with these learning objectives. We will review the current science of pediatric cardiac arrest and allow EMS clinicians to apply evidence-based practice to maximize good outcomes for pediatric cardiac arrest. We'll define medical futility of resuscitation for pediatric out-of-hospital cardiac arrest, and ensure that you know the details of the Maryland TOR protocol as it applies to pediatric patients. And finally, by the end of the next hour, I hope for you to understand the important role of judgment calls and exactly what all needs to be considered by EMS in the application of termination of resuscitation for pediatric patients. So let's start by looking at a little more positive direction. What can we do to improve Maryland outcomes for pediatric out-of-hospital cardiac arrest? Each year in Maryland, we have about 180 children with out-of-hospital cardiac arrest where CPR is initiated. These are the ones that end up in what's called the CARES data set. And of all children who get EMS CPR, just under 10% end up surviving to hospital discharge. So we had a total of 32 over the past 2 years. And just about half of those survivors survive with a meaningful neurological outcome. This is a little disheartening. Can we improve the outcomes after pediatric cardiac arrest? Well, I definitely think we can. Look at the blue lines here. These are the rates of survival after in-hospital cardiac arrest, and you can see massive improvement in outcomes for both children and adults over the past 2 decades. But there is a really big gap between in-hospital and out-of-hospital cardiac arrest survival. Those orange lines for the out-of-hospital patients are moving in a direction of improvement a little bit, but the gap is actually widening. And more than that, if we look at the graph on the right, the adult survival from out-of-hospital cardiac arrest, that orange line on the bottom of the right, we see that adult survival is improving at a measurable rate over the past 2 decades, while pediatric out-of-hospital cardiac survival rates have maintained relatively stagnant. So how can we close this gap? The plan to improve cardiac arrest survival in adults is pretty well known. This is what the AHA calls the chain of survival. High quality, high performance CPR, focusing on chest compressions, early defibrillation, and what they list here as advanced EMS mostly translates to epinephrine. We know that a percentage of folks will respond to epinephrine, and it does increase overall survival rates in adults. So how is that similar or different than the pediatric chain of survival? Well, anyone of any age in cardiac arrest will benefit from high-performance CPR, and the basic rules of high-performance CPR are identical for all ages. Compress deep, allow full recoil, aim for a rate of 100 to 120 compressions per minute, don't overventilate, and minimize interruptions. There are multiple studies linking the implementation of high-performance CPR, or what's called pit crew CPR programs, with improved survival. These studies have mainly been conducted amongst adult cardiac arrest patients, but they've shown generally a doubling of survival rates in multiple locations. In addition, if we look at more than 2,000 pediatric out-of-hospital cardiac arrests in the ROC, or Resuscitation Outcomes Consortium data set, they found a strong correlation between time on scene and survival. There is nothing more important for patient care than delivering good, high-performance CPR. And it is 100% impossible to do good CPR while you are running across somebody's front yard with a baby in your arms. And it is nearly impossible to do it in the back of a moving ambulance. So CPR works. But for kids, the P in CPR, that's cardiopulmonary resuscitation, it's very important because most cardiac arrest in children is secondary to hypoxia or respiratory failure. Opening the airway, giving rescue breaths, and doing good quality ventilation management is a key to improving survival. Ventilation is important, but that is not to say that the intubation procedure is important. Why not? Well, the time it takes to set up for and perform intubation is time you're not ventilating. It is seconds that are wasted and delays in other important maneuvers. I would much prefer EMS to be focusing on intraosseous access. In addition, if the tube is misplaced, it's got catastrophic results. This was first noticed in children with in-hospital cardiac arrest, where intubation was associated with worse outcomes, about a 5% decrease in survival rate compared with those who were bagged. The finding is even stronger in out-of-hospital cardiac arrest. Using the CARES data set, this group analyzed airway management in pediatric out-of-hospital cardiac arrest and survival. The odds of survival were highest in the bag valve mask group. They were more than twice as likely to survive compared with children in either endotracheal intubation or supraglottic airway groups. So you may be asking, why on earth is anybody intubating children in cardiac arrest? And that is exactly the right question to be wondering. Meanwhile, the alternative is rapidly available. It performs very well. To review the technique for bag valve mask in ventilation, choose the right size mask. Hold it with a good seal. Squeeze the bag just enough to see the chest rise and then let the chest fall. Aim for a rate of about 1 breath every 6 to 10 seconds. Finally, epinephrine does make a difference. And there is more evidence to support it for children than adults. Early emphasis on intraosseous access and epidosing can make a difference. In that Resuscitation Outcomes Consortium study, where they analyzed about 2,000 pediatric cardiac arrests treated by EMS, the time to epinephrine administration showed a significant positive association with survival. If epinephrine was administered more than 10 minutes after EMS arrival, the chances of survival were 57% lower than if epinephrine was administered sooner than 10 minutes after EMS arrival. And when they broke this down even further, every 1 minute of delay in epinephrine led to approximately 9% decline in odds of survival. This strong finding was repeated in an analysis of the Japanese cardiac arrest Utstein registry, where they found that late epinephrine compared with early epinephrine had an 80% decline in long-term survival. Wow. So this is a study that has gotten a lot of attention in the EMS press. Down in Polk County, Florida, that's a large suburban rural county halfway between Tampa and Orlando, smack in the middle of the state. The EMS agency for that county set out on a quality improvement effort to increase survival from pediatric out-of-hospital cardiac arrest. And well, they had nowhere to go but up, because in 2012, 2013, for their pre-intervention phase, they actually had 0 survivors out of 38 cardiac arrests. They created a bundle of interventions that they phased in over a period of a year or so. And after their protocol changes and education rollouts, both the rate of return of spontaneous circulation, rate of ROSC rose to over 30%, and their neurologically intact survival rose to 25%. Very, very impressive. So what was in their bundle? They tell us that it included pit crew high-performance CPR, a focus on precise ventilation, emphasis of early intraosseous access, and early first dose of epi. They simplified epinephrine dosing to create 3 rounded doses for infants, children, or adults, instead of the more precise weight-based calculated doses. And they trained a cadre of ALS providers with advanced airway training. Now, I have serious questions about this study. This has been well promoted, but the authors have not shared a lot of details that would allow other jurisdictions to replicate the results. And in the jurisdictions I'm aware of that have tried to replicate it, they haven't seen anything close to this level of success. Nonetheless, there is a definable bundle of interventions that are scientifically supported. And I, for one, would like to improve outcomes of pediatric cardiac arrest for Maryland children. So with that in mind, what have we done with a Maryland EMS for Children bundle for pediatric out-of-hospital cardiac arrest? We are already in the thick of this. In Maryland, we created a high-performance CPR protocol about 3 years ago. And you may have participated in one of our high-performance CPR workshops. If you have, thank you, and I encourage your colleagues to check it out. In addition, we have the computer simulation mannequins available for borrowing from regional offices. You can check with the pediatric champion for your jurisdiction about possibly having one of these sessions in your own station. In addition, we have put into the Maryland Medical Protocols direction to stay on scene for resuscitation. All ages. This is the current protocol. Resuscitate in place for a minimum of 5 2-minute cycles. That means on the floor of the bedroom, in the kitchen. It does not mean head to the back of an ambulance parked outside. The time it takes to move a patient is precious time lost in the chain of high-performance CPR. In addition, we are shifting focus to quality ventilation over the intubation procedure. And in the 2020 protocols, you will see changes to the epinephrine administration for cardiac arrest. It actually goes for all ages. Shifting to a more clear-cut 1 dose every 4 minutes from the prior 3 to 5 minute range. If you look at the algorithm for pediatric cardiac arrest, you see intubation is never mentioned. After CPR and ventilation, the priorities are AED or monitor, and then vascular access and epinephrine administration. This is not a big protocol change per se, but it is important that this continue to be promoted in education and change the culture of priorities. As we press forward improving the care of out-of-hospital cardiac arrest for children, we have to face the likelihood that most of these cases will not end with good outcomes. When we ask EMS to spend more time on scene and get farther into the cardiac arrest algorithm before transport, it is important to have reasonable options for termination of resuscitation when it reaches a point of medical futility. Maryland introduced our adult termination of resuscitation protocol in 2013, and that specifically excluded patients under 18. Like we saw in some of the earlier discussion of cardiac arrest, childhood cardiac arrest is different from adult. The etiologies, the outcomes, and also the social, emotional, legal, and administrative factors. So What is the benefit of even having a termination resuscitation protocol? Well, benefits include avoid giving false hope to a family. We want to avoid high-risk transport, not only for the crew inside a racing ambulance, but for a family rushing to the hospital in their own vehicle, and for other people on the road. There's also a point at which we must reduce resource use for futile interventions. And most importantly, having a roadmap for termination is a key to improving CPR performance, as EMS should stay on scene to resuscitate in place. So pediatric TOR has been discussed in the abstract for several years, and we've created room over the years in the Maryland protocols for pediatric TOR in exceptional circumstances. Now, in 2020, we have a formalized protocol to guide EMS for more widespread use of pediatric termination of resuscitation without online medical direction. We have defined criteria for pediatric termination for medical cardiac arrest. EMS clinicians may terminate resuscitation for a pediatric patient defined as someone who has not yet reached their 18th birthday after the patient has received a minimum of 15 2-minute cycles of CPR and at least 1 dose of epinephrine, and the patient is in asystole and has a sustained end-tidal carbon dioxide level less than 15, and in the judgment of EMS and law enforcement on scene, there is adequate social, emotional support and safety for all civilians and professionals on scene. And in the judgment of EMS and law enforcement, the scene is amenable to leaving a patient on scene if the patient does not meet all these TOR criteria. EMS is advised to continue resuscitation, reevaluate at the next rhythm check, or consider transport. Meanwhile, for trauma arrest, we have aligned as much as possible with the adult protocol, including setting a definition of an adult as one who has reached their 15th birthday, which means that the 15, 16, 17-year-olds who now fall outside the current TOR will be allowed to undergo termination resuscitation based on adult guidelines starting in 2020. For children 14 years and younger, the pediatric TOR criteria include: EMS clinicians may terminate resuscitation for a pediatric patient, someone who has not reached their 15th birthday, following 5 2-minute cycles of CPR according to the trauma protocol trauma arrest. And as a reminder, that refers to the importance of going through the reversible, correctable causes of cardiac arrest, like needle decompression thoracostomy. So following 5 2-minute cycles of CPR, if the patient is still without return of spontaneous circulation, and there is asystole on the monitor, and end-tidal carbon dioxide is less than 15, and in the judgment of EMS and law enforcement, there's adequate social, emotional support and safety, and in the judgment of EMS and law enforcement, the scene is amenable. It is important to note that termination of resuscitation exists separately from the protocol for pronouncement of death in the field. The so-called obvious signs of death, like rigor mortis or dependent lividity. We see that a large proportion of pediatric cardiac arrests in Maryland actually meet the existing criteria for obvious signs of death, and EMS is already authorized to not start or stop CPR once these signs are recognized. We have placed this in the TOR algorithm as a reminder that if CPR was started by a bystander or another first responder, EMS can and should stop CPR once they recognize obvious signs of death. So how did we get here? We began creating this protocol by sorting through all the complex factors involved in pediatric out-of-hospital death. It is completely natural that elderly people at the end of life die. And it is completely unnatural that any child dies. Of course, on an individual level, there are sudden, shocking deaths late in life, and there are long anticipated deaths after chronic illness in childhood. But part of what makes adult TOR relatively easier to comprehend is that while it is difficult, there is a generally accepted plan for handling the death of an older adult in the home. On the other hand, pediatric deaths are very high-stress events. Most pediatric deaths are unexpected, and therefore, they fall under the domain of the medical examiner or law enforcement for the protection of forensic evidence. And all pediatric deaths involve a family whose needs must be considered. Setting some of those complex factors aside, let's consider for a moment the science of pediatric TOR, or answer the question of how we define medical futility in pediatric out-of-hospital cardiac arrest. We'll turn to the large analyses that have been done based on the Japanese databases of out-of-hospital cardiac arrest. These are the same data sets that were used to come up with the time definitions beyond which resuscitation can be considered futile for adult patients. For pediatric patients, it appears that if there is no return of spontaneous circulation by about 32 minutes of CPR, there is a less than 1% likelihood of survival. But in addition to that time course, this same study also found strong association with survival with 3 other factors. The first is those with a witnessed arrest. Children with a witnessed arrest do somewhat better, about 3 times the odds of survival compared to children with unwitnessed arrest. But dramatically, kids with a rhythm other than asystole do much, much better. 16 times the odds of survival for those with a VFib or a VTAC rhythm compared with asystole, and 5 times the odds of survival for those in a PEA rhythm compared to those in asystole. So this is part of why we added the requirement to show asystole to our Maryland pediatric termination of resuscitation criteria. A heart that is still beating very weakly in PEA or an electrically active heart is a child that might potentially still benefit from additional care. Just last year, one of the first reports came out that specifically looked at duration of CPR and outcome for children with traumatic cardiac arrest. This is not all children. This is a blunt trauma group with motor vehicle crashes as their etiology. They looked at 4 years of data and analyzed 30-day survival outcomes. They had about 600 patients over that time period. 3% were alive at 30 days, and about 1.5% had a good neurologic outcome at 30 days. Every single one of those patients with a good neurologic outcome had return of spontaneous circulation before they reached the hospital. This study found the likelihood of neurologically intact survival was less than 0.5% after 5 minutes of CPR without return of spontaneous circulation. And the likelihood of survival in any form was less than 1% before 15 minutes of CPR without ROSC. You may recall that for Maryland, we chose a minimum resuscitation time of 10 minutes for traumatic cardiac arrest. This was mainly to align with the existing adult protocol. By 10 minutes, the possibility of neurologically good survival suggested by this Japanese analysis is less than 0.25%. And we further added the restriction to our Maryland protocol to show that the patient is in asystole, because the adult data suggests that asystole after trauma arrest is universally fatal. However, if you look at this literature and you want to consider continuing CPR for another 5 minutes after a trauma arrest, it's not unreasonable. There's little harm in trying. As in the future, as more data comes out, we may find that we want to move this time limit. And finally, we turn to the really hard stuff, the non-scientific considerations in pediatric termination of resuscitation. We conducted a series of focus groups, speaking with groups of healthcare and other public safety providers in every region of Maryland. We spoke to EMS clinicians and EMS medical directors. We spoke to hospital and ED staff, medical examiner, forensic investigators, child fatality review committee members, and law enforcement. We took away 3 important lessons. First, that there is a lot of variation across the state of Maryland regarding how a scene can or should be handled. There is wide disparity in the availability of medical examiner forensic investigators, particularly when the deceased person is under 2 years of age and special credentialing is required for that scene investigator. In some parts of the state, it can be a number of hours for a medical examiner forensic investigator to respond from outside the county. And we heard some really dramatic stories of how difficult that can be for law enforcement or EMS to wait on scene for a forensic investigator to arrive. On the other hand, we also heard about a lot of variation in receiving hospital attitudes. There are parts of the state where hospitals are clearly very welcoming and see it as their mission to receive a family and a recently deceased child to provide social work and other grieving services. In some parts of the state, the hospitals are adamant that a deceased person is not a patient and therefore should never be delivered to an emergency department. Not only is there variation across the state, there's variation even within regions. And it quickly became clear to us that this was not a one-size-fits-all solution. And we needed to make room in the protocol for EMS clinicians to use their judgment and to use their knowledge of their local hospital, law enforcement, medical examiner landscape to make a decision about the best course of action. We did hear from our clinicians about some common scenarios where the idea, the concept of pediatric termination of resuscitation is more palatable. For example, unwitnessed arrest, especially an infant who is found when the family wakes up in the morning and is cold and stiff and has clearly been deceased for some prolonged period of time. It is widely understood that resuscitation is not going to be successful in those cases. In addition, the multiple casualty trauma incident is easy to wrap one's head around. When you have a multi-vehicle crash on the side of a highway with a large response of various law enforcement, fire department, EMS personnel, it is relatively simpler to declare obviously deceased patients at the scene and hand over the scene intact for in situ investigation process and handling by the medical examiner. And finally, EMS clinicians were able to either describe events they had been part of or hypothesize a scene where a child with a known terminal condition might have EMS called to a home, but it rapidly becomes clear to both family and the EMS crew that the child is at an end-of-life state and the family is already on their way to being prepared to handle the news of the child's death. Nonetheless, it came through loud and clear that the death of a child is a heavy emotional burden on EMS. And I can't even tell you the number of times it was expressed to me that EMS clinicians need more and better resources to manage the secondary trauma of being part of the death of children. The takeaway there is that we wanted to make sure that the pediatric termination of resuscitation protocol did not add to that already heavy burden. We wanted to make sure that EMS clinicians' judgment and instincts are able to lead the way, and if they don't feel comfortable, they don't have to declare the patient dead. So we all know the concept of scene safety, but I want to think about what that means in the context of a pediatric cardiac arrest call. What kind of ways might a scene be unsafe? I'm just going to leave this hanging for now. Give it some thought. As we come to some scenarios in the next 10 minutes or so, we will have an opportunity to talk about it a little bit more. But when we think about scene safety, I'd like to take a very broad view of the terms. This is not only about physical threats or violence, but it's really important to think about emotional safety. There's a term around traumatic events called secondary trauma, meaning that the grief or the long-lasting emotional toll can be as bad as the primary event itself. So we need to consider the needs of the child's family. Maybe there's neighbors or other bystanders at the scene. Of course, the EMS professionals, and also law enforcement, maybe other first responders who could be on scene. And it's not just the people on scene to consider. It was really interesting to hear on our focus group tour, in some parts of the state, EMS was really concerned on the toll taken on hospital personnel who would be impacted by having to also be a party or a witness to a child's death. And similarly, there are neighbors, friends, distant cousins who could be impacted even if they're only hearing about a story secondhand days afterward. So we need to do this right. And what does it mean to do it right? Let's pause for a minute to talk about delivering news of death. This could be a 1-hour module all on its own, but here is the 30-second highlights. If possible, find a quiet area to sit down and talk with the caregivers. Deliver the news with compassion. Find out and use the child's name. Allow the child to be an individual person. Using the name is an important show of respect. I can't emphasize enough how important it is to use concrete words and, in fact, a very simple sentence. This is not a time for euphemisms. There's no passed away, we lost him, he's moved on. Instead, use the child's name. Sally is dead. Sally has died. Period. Pause. Let the family have that news sink in. It is okay to show emotion. Do not worry about your voice cracking or tearing up. If you are not capable of delivering the news without having a complete breakdown, see if there's someone else who can give the news, or maybe this is not an emotionally safe scene. But you do not need to be stone-faced. And in fact, families appreciate the showing that you are a human being who cares about what is happening. If there's not already a family member, a neighbor, a pastor there supporting the grieving family, ask if there's someone you can call to offer them social support, to drive them to a hospital or wherever else they may need to go to help them access mortuary services. And I can't emphasize enough how important it is to deliver this news and then accept whatever response the parents or caregivers have without judgment. People respond in a variety of different ways, some with crying and screaming and wailing, others by going stone-faced and unresponsive, others by mentioning strange, trivial details like, oh, well, I guess I don't need to order pizza. It's all okay, and it is not our job to judge. Once the news has been delivered, we need to think about post-mortem processes and what operational considerations may be a factor. As mentioned before, the medical examiner forensic investigator process is highly variable across the state, particularly when we're dealing with a deceased person who is under 2 years of age. It is a specially trained, credentialed group of forensic investigators, and they can be in limited supply. So know what your process is and know what their availability is going to be in your jurisdiction. In addition, law enforcement may have its own crime scene investigation process. In both cases, this requires some coordination with law enforcement and with the forensic investigators to know how long it is going to be before the scene is cleared, and make sure that your EMS unit is able to hand over to law enforcement in a timely manner. Getting back to that question of the attitudes of receiving hospitals, it may be tricky to decide whether to transport the patient as a deceased person to a hospital or continue CPR and transport as a working code. For EMS working in parts of the state where it is known that the local hospitals will not accept a patient who has already been terminated in the field, it is advisable to continue working the code and transport to the nearest hospital in the case that you are not able to leave the patient on scene. And finally, in some parts of the state, there are processes already established where there is a long period of time for medical examiner or forensic investigator arrival, but hospital morgue space has been made available. So the deceased patient could be transported directly to a hospital morgue if they are not able to be accepted in the ED. The variety of resources that I want to point out for you, we won't get into great detail, but these can be helpful. The first is a project called Compassionate Options for Pediatric EMS, run out of the Kentucky Board of EMS and supported by the Federal Emergency Medical Services for Children Grants Program. This is a series of training videos and resources that can help provide some additional education and training on how to communicate with families and how to take good care of yourself in terms of secondary trauma prevention. There are a number of solid educational courses. I myself am a big fan of the Pediatric Education for Pre-Hospital Professionals, the PEP program, which includes a module or a chapter on dealing with death of a child by EMS. This is also addressed as a module in the PALS course, the Pediatric Advanced Life Support course, although that course is primarily aimed at in-hospital providers and in-hospital death. The EPC course, sponsored by the National Association of EMT, also includes a module on death of a child and how EMS clinicians can both communicate with the family and understand the processes involved, as well as take good care of themselves dealing with the aftermath. Speaking of the aftermath, Critical Incident Stress Management Services is a good first line of response, and all Maryland clinicians have access to CISM support. It can be accessed 24 hours a day by calling SysCom at the phone number listed there, or through an internal team depending on your local jurisdiction. And finally, we have 2 pediatric specialty base stations that are staffed 24/7 with pediatric EMS experts, and we are always happy to receive your calls. If there is ever any question and you just need some support or some backup, that is what we are there for. Finally, if there's ever any doubt about whether the patient meets the criteria for pronouncement of death in the field, if there is any doubt about whether the patient meets the criteria for termination of resuscitation, if there is any doubt about whether the family, yourself, your partner, the law enforcement on scene can emotionally handle the declaration of a termination at the scene, if there is any doubt about whether the resources are in place from the medical examiner or law enforcement to take over the scene and release you back into service, it is always an option to continue CPR and transport. That is never a wrong decision. I thank you very much for your attention. We have a series of scenarios that we will turn to either videotaped with me or an in-person discussion with your pediatric champions and educators. And if you have any questions, you can always reach out to me at the MIEMSS EMS for Children office by using the links found on the MIEMSS website.
California Casualty has been endorsed by the MSFA for 10 years for its auto, home, and renter's insurance. It is our honor and privilege to protect those who protect our communities. Happy 10-year anniversary to the members of MSFA. Thank you for all that you do. For more information about our program, please visit www.calcas.com/MSFA. We look forward to seeing you at various local, county, and state events.